Thanks to Topcon and to the organizers for really a tremendous meeting. And I particularly want to congratulate Rick Spade on putting together a super scientific program. I'm going to speak about glaucoma as a clinician and how we might be able to use the information in these technologies to really change the clinical paradigm and move away from certain types of tests that are difficult or uncomfortable for our patients, such as visual fields. We're fortunate to have a lot of support in our laboratory. Well, we're in the middle of a revolution for glaucoma with rapidly changing paradigms. So there's a lot of discovery. That discovery ranges from technology, as we're discussing today, to epidemiology, but also into the genetics of disease and disease progression, disease detection, both in families and in larger groups of individuals. Unlike AMD, only about 10% of the underlying genetic basis of glaucoma has been described. This is resulting in new advances in translational science with novel interventions, surgeries, medical therapies, the application of telemedicine, just as you're doing for retinal disease. As Don mentioned, machine learning is going to definitely change the way we interpret all of these images. And the community, the general population, views us as artificial intelligence applications. Our colleagues in medicine fear artificial intelligence, of course, because they think that they're going to be replaced by machinery. And all this leads to individualized disease detection and treatment. So we know a lot about glaucoma now. We know about all these linked structural changes from the macular disease that Don mentioned. And I cannot overemphasize that point that the disease is a central disease. It's not a peripheral disease where there's peripheral loss of vision, but it's also a central disease affecting ganglion cells across the entire retina. We can image the ganglion cell pathway through the axons as they approach the optic nerve. We can do that circle scan around the disc that Don described. And also our clinical examination is still very meaningful because we need to look for disc hemorrhage and areas of parapapillary atrophy. Characteristics of the rim, such as notches, can be detected by automated technology. The disease is all linked at the lamina cribrosa, which is the purported site of injury in this disease, and separates it from all of the other optic atrophies. But actually, you can then look back to the brain, look at the optic nerve in cross-section, lateral geniculate, and down back to visual cortex. So this is a series of transsynaptic degenerative processes that get back to the brain, which tells us that concepts like neuroregeneration for glaucoma are going to be rather difficult because if you can reduplicate retinal ganglion cells, but they need to make a connection someplace, and the connections in the lateral geniculate are gone, that's going to be highly problematic. We also know a lot about the stages and the progression of the disease. This is a cartoon from an article we wrote along with Bob Weinreb more than 10 years ago that just describes the glaucoma continuum from normal through cell death, loss of the ganglion cells, and nerve fiber layer loss, all the way to visual impairment. Now, if you look at the automated parametric change that we typically have, that's rather late in the course of the disease, particularly if you're using a grid that has 6-degree spacing. In other words, typical 24-2 and 30-2 program that Don mentioned there's room for a 5-degree scotoma between those points. And when you're testing certain regions of the field, particularly the macula, we need to do 10-2 testing, which we do for virtually all of our patients. We know a lot about the disease process because we understand a lot about risk from clinical trials, and there's been a whole number of clinical trials done worldwide looking at glaucoma risk assessment. And it's in this underlying basis with all of this knowledge that we need to apply our technologies. So with all of this knowledge, why is there so much difficulty diagnosing glaucoma? Well, clinically speaking, one of the major reasons is that there's a very wide appearance in the optic disc. That's not just related to disc size, as I'm illustrating on this slide, but also related to tilt, parapapillary atrophy, media opacity. All of these things have limited the ability of clinicians to accurately diagnose the disease. We spent much time, great deal of time, trying to educate our colleagues without great effect. In the United States, 50% of people with glaucoma are undiagnosed. That doesn't mean that 50% haven't been examined. Most people have been examined. The disease has just been missed when we ask clinicians to look at the disc and characterize their patients. There's also no proven screening methodology for the disease. Essentially, to diagnose glaucoma, people need a complete eye examination, including perimetry. There are system limitations for that in terms of cost, access. There are human limitations, as I mentioned, related to training, ability, and knowledge. In fact, visual field testing is highly unreliable. In the OATS trial, the ocular hypertension treatment study, if a patient had a normal visual field test and then had an abnormal test on the visual field, upon the third test, 86% of patients did not have a repeatable visual field abnormality. So the visual field is highly variable and not a good test to screen for the disease or to determine if disease has progressed. That type of testing, where you do one test over and over again, is confirmation of damage. And that requires multiple repeated measures. It can be used as a research tool for NIH trials or for drug trials, but it's not very useful clinically. In fact, clinically, what we do is corroboration of damage. We look at the disc, we look at the field, and then we look at the two of them and see if there's a match in terms of structure function. I was having a conversation earlier with Rick about structure-function relationships, and it was said in the past that perhaps there's a disconnect between structure and function. Well, we now know with OCT that that's not really true, that there's a precise structure-function relationship in virtually all of our patients. This is an article, actually, Don will be presenting this paper at ARVO, and essentially by looking at localized regions of damage, there's a very strict structure-function correlation throughout the glaucoma spectrum, even in very early disease. So what are our options for corroboration of damage? Well, we can assess the structure-function relationship, as I just mentioned to you. Look at the optic nerve, a clinical exam, a drawing or imaging, and look at visual function using, most often, CETA-SAP, standard achromatic perimetry. Or if we're in a research setting, we can sometimes use a function-function corroboration approach, which we've done for prior studies, to determine that a functional deficit is really present. You can do perimetry and, for example, multifocal visual potential to confirm the presence of a visual field deficit. But I think we're in the era where we can really do structure-structure assessment. And that structure-structure assessment, I think, is going to greatly change the ability to and a need to do these other types of assessments for many patients. So we can look at the neuroretinal rim anatomy and the nerve fiber layer thickness and its pattern and corroborate a notch and a nerve fiber layer defect, and I don't need any other information to make a diagnosis of glaucoma. I don't need a visual field deficit. We can combine, as Don mentioned, the ganglion cell interplexiform layer thickness or pattern. We can even use lamina cribrosa information in theory, and as I mentioned, things like disc hemorrhage also allow us to do that structure-structure assessment. Imagine if we could combine all of these parameters into some kind of machine learning approach. We might be able to greatly eliminate the use of visual fields. Today I'm just going to talk, though, about the things that Don mentioned, which are the nerve fiber layer and the ganglion cell complex and its pattern. I'm going to use the Hood report. The Hood report's highly useful. It's in the Topcon equipment, which we really don't have available clinically in the United States, but now we will. But it uses all of these things listed on the left for your convenience, looking at the circumpapillary RNFL scan to inspect it visually to make sure that the scan doesn't have any defects. The plot that Don mentioned, focused on the macula in the center, remembering that virtually half of the visual field, half of the nerve does not project any place into the visual field that we currently test. looking at the en face slab image, the neurofibrillary thickness map, the macular thickness map, the probability maps, and so on, with the visual field points on top of the probability plots. And that is key because it allows the clinician to go back to the field and determine whether or not a field defect is related to one of these points. And very often what we find is that fields that were passed spuriously by clinicians as being not really important do have subtle defects in them, particularly on the 10-2 testing, that normally would have been passed as normal, but we now know are not normal. If you want two articles to read, Don wrote these two articles looking at the structure-function relationships in the macula. He alluded to them in his talk, and further into the periphery, remembering that we're making an assumption that the entire nasal half of the disc is unimportant. We have no functional correlate. So we're already in an area where we're doing structure-function relationships on only half of the disc. It might be the most important half, because that relates to macular function, but still, we're already down the path of just looking at structure. We also know that the changes that occur in the macular region are occurring simultaneously with those that occur in the neurofibrillary. Obviously, the ganglion cell and its axon. If you lose a ganglion cell, you lose the axon. Sometimes you can detect changes in ganglion cell complex or the neurofibrillary slightly earlier or later, but in general, they're occurring at the same time. And this is work that's now being done worldwide. This is from Kiho Park in Korea, demonstrating the same kind of, classic structure relationships and measurement. These measurements of macular thickness are very, very reliable. So let me just show you a few clinical examples. A healthy eye with a normal visual field. I'm showing you both a 24-2 and a 10-2 visual field. And we can use the Don's approach to evaluate it, and it's got that four-step approach, which I'm kind of leaving at the bottom of each of these slides to remind me, as a clinician, to use the stepwise approach that he uses, because most of the time, glaucomatologists do the opposite of what retina specialists do. Retina specialist evaluates every image very carefully, but in general, a glaucoma specialist really just looks at the metrics, often just looking at the average retinal neurofibrillary thickness. So if you ask a glaucoma specialist if the disease is progressing, they'll say, well, if the mean neurofibrillary thickness is worsening by -1 micron per year, the patient's getting worse, and they'll leave it at that. So they're not using the technology. So we can look at the scan; it's intact. Has not failed. The circumpapillary image shows that the neurofibrillary thickness is normal. Both the slab en face image, macular thickness map, and the probability map are normal, and you can superimpose the visual field deficit on it. Pretty much everything is normal. Now, the key of looking at the report is not to look at one part of the report, but to look at all of the parts of the report. So if I look at the neurofibrillary thickness and macular thickness, they're both normal. The chance of having glaucoma in that setting is extremely low. And I can actually take this plot, the glaucoma continuum, and I can just kind of replace it with, normal, glaucoma suspect, early, moderate, severe field loss. And eventually, I can just kind of put a little arrow and say, well, this is a normal eye. And I'm going to come back to using this in a little bit, because not only can we use this type of approach for diagnosis, but we can use it for staging. And staging becomes critically important for our patients. And we can show many, many examples of normal patients. And we should not underestimate the value of a normal scan. A patient can't fake a normal visual field test. It's very hard to do. The power of a negative test to place a patient and call them normal is important. It allows us to take that nebulous category of glaucoma suspect, the one that we hate to use, and allows us to begin to whittle down the glaucoma suspect category. So a lot of those patients who have a large disc, large cup, completely normal image, they're really normals. They do not have to come back and see us for quite some time. So that glaucoma suspect with a large cup disc ratio, if you ask a resident in training, they say, come back in 3 months, come back in 6 months. We tell them to come back in 2 years or 3 years for reassessment if we have some level of suspicion about them. Perhaps if they had a family member with disease. But otherwise, we can call a lot of those glaucoma suspects normal, not apply resources to normal individuals. It's a waste of time and money, and apply the resources to the people who actually have disease. This is a patient from the ocular hypertension treatment study. 20 years of essentially normal fields finally may be developing something abnormal. But got field tests for twice a year for 20 years. Imagine if we were getting OCT images during that time and they were all constantly normal. I wonder what the value of these visual field tests would have been. Probably very, very little. And probably you could come back, do a field test every 3 or 4 years in a patient like this and just follow them with imaging. The retest variability for these is remarkably good. This is from Gustavo de Moraes' NEI grant. The dates are up here, so we repeated tests 3 times as baseline in terms of entry, and you can follow whichever pattern you like, and the tests don't change very much at all. Highly reproducible, unlike visual fields, which are not very reproducible. So imagine we're asking our patients to spend 20 minutes doing perimetry for a test that has low reliability. And again, for healthy eye. Same thing's true for glaucomatous eye. The reproducibility in a glaucomatous eye is also excellent. See the same type of damage in the same pattern virtually every time you do the test. So there's high reproducibility. So I showed you a normal patient, so just a classic glaucoma patient with thinning of the neuroretinal rim. Everyone here would probably make that diagnosis. Superior arcuate type of defect, paracentral type of defect on the 10-2. There's a very thin retinal nerve fiber layer that's evident right here. There's going to be some macular damage that you can see in this location. Inferiorly, there's a wide retinal nerve fiber layer defect inferiorly. There's also nerve fiber layer defect superiorly as well. This nerve fiber layer defect goes along with this defect here. And when you flip it to the field view and place the points of the visual field on it, you'll notice that there's only one point on the 24-2 that's likely to be affected in this region, but if you put the 10-2 points on it, there's going to be a lot of damage in the paracentral region. And this patient we could call already moderate glaucoma damage. Now this patient has already moved through this entire spectrum of disease and already passed at the end of the disease process. We really need to pick up these diseases much earlier. So an example of early glaucoma, very similar type of image, borderline abnormality here, slightly into the red, inferior defect, field view abnormality superiorly. Here's a visual field defect, 10-2, and again, early type of glaucoma damage. The other eye is completely cupped with extensive 10-2 lost. So here's an example of a patient who has a really full visual field. I would look at this nerve and I would say that's glaucomatous. A little bit of abnormality of a visual field defect, perhaps early disease, but there's a lot more loss on imaging. Here's that visual field defect close to fixation. So instead of calling this patient early disease, you can actually recast it and say there's central visual field loss. The patient's disease is much more advanced based upon the accumulation of the data in the testing. So this is how glaucoma diagnosis version 1.0. We stage the disease, we then get the OCT, and then we have a value of the visual field. In the future, I think we'll have the OCT done first as part of a wider screening process. Then we'll stage the disease And then the visual field will have varying value. And in some cases, there won't be any value. Don mentioned his article on hybrid learning, which I think will incorporate much more than the information we're currently using. So to conclude, we have a series of unmet needs in glaucoma. We have diagnostic and monitoring tools that I think are changing everything. And those diagnostic tools will then impact this sequence of events, clinical trial endpoints. How do we assess therapeutics, neuroprotection, enhanced blood flow, and all the other ways that we intend to treat glaucoma in the future and apply it to precision medicine. So in summary, OCT reduces the need for repeated perimetry in clinical practice for early glaucoma, for glaucoma suspects, and increasing the combination of structural assessments will increase and help us with our sensitivity and specificity. Thank you.